name is Patricia Rios, and your host for today's webinar on exploring rare types of bladder cancer tumors. During this webinar, we will explore rare bladder cancer subtypes, how they differ from more common forms of bladder cancer, and why they can be challenging to diagnose and treat. Our two amazing guest presenters will discuss current research into tumor biology and genetics, global collaboration efforts, and how clinical trials are advancing care for patients with rare bladder cancers. We will first hear from Dr. Al-Ahmadie, who is a board-certified pathologist at Memorial Sloan Kettering Cancer Center, followed by a presentation from Dr. Roger Lee, a genitourinary oncologist at the Moffitt Cancer Center. So with that, I'm going to transfer the screen or hand over the screen to Dr. Al-Ahmadie. As a reminder, after the presentation, we will have a dedicated Q&A session with both of our experts. So I encourage you to submit your questions throughout the webinar. And without further ado, Dr. Al-Ahmadie, the screen is all yours. Thank you so much for joining us.
Thank you. Thank you, Patricia. Hello, everyone. Good evening, good afternoon. My name is Hikmat Ahmadi. I am a pathologist, as Patricia mentioned, at Memorial Sloan Kettering Cancer Center, which means if you heard of whenever there's a diagnosis of bladder cancer or any cancer, this means someone like me had looked at a set of slides from a patient and made the diagnosis of cancer, bladder cancer in this setting. I'll go over some of the steps, some of the things that we do, but also share with you some what is relevant about these rare subtypes of bladder cancer and why we call them the way they are, why we coin the names, and then have plenty of time at the end for questions. I apologize in advance if there's any term that may be too technical, you may not be familiar with, but we're happy to answer that and try to address it anytime after this or later or anytime after the webinar. Even we're happy to be of any help. These are my disclosures. And just to put things in perspective, we're going to focus on histologic subtypes or rare subtypes of bladder cancer, but just to put things again in the context of what we are dealing with. This is, bladder cancer. The majority of bladder cancer cases, as diagnosed, they will be not the rare subtypes or not these histologic subtypes that we'll be dealing with. Most of patients will have the non-muscle invasive bladder cancer, the superficial disease. The subset of that will include these histologic subtypes is the invasive disease, which means it's a subset of the non-muscle invasive disease here, any tumor that invades from the surface urothelium into the bladder wall. It could be superficial, it could be deep, but these histologic subtypes apply to this part of bladder cancer when the tumor invades into the different layers of the bladder. So it's a small subset of the overall bladder cancer in its different settings. But once you get into that group, then there's a lot of names, a lot of entities that are grouped in this, but still, even when you have invasive urothelial carcinoma, then there is still a most common subtype, which is a regular urothelial carcinoma. Some people refer to it as a classical, traditional urothelial carcinoma. They say more scientific or medical term for it is not otherwise specified, or NOS. If you hear the word urothelial carcinoma, NOS means it's urothelial carcinoma that does not have features to otherwise will make it called or labeled one of these other subtypes. And then there are, within these subtypes, there are subtypes that are very common, like squamous differentiation, when a tumor forms or shows features that look like squamous. But then there are some other rare subtypes, and these are the names here. And I'm going to show you some quick pictures of reference so you can have an image of that you can associate with the name. It's probably some of you who have more photographic memories may have an easy link to these histologic subtypes. And this is what I mean by this. Again, our reference point is urothelial carcinoma, not otherwise specified, NOS, regular, classic. Urothelial carcinoma, when a tumor starts forming, has morphologic features under the microscope, and this is done under the microscope. We examine this tissue under the microscope. When there is tumors showing things that may look like a skin, become squamous, we call it squamous differentiation. When a tumor starts forming glands, something that you would see in like the colon or the stomach or the thyroid, that we use the term glandular because the tumor is kind of from being urothelial, it's trying to form something else like a gland. When it starts making structures that look like germ cell tumors, we call it trophoblastic differentiation. When a tumor has a unique morphology of these small tumor clusters arranged in a clear space, we use the term micropapillary, and that's why the term plasmacytoid in a tumor resembles some of the blood cells, the plasma cells. It resembles it, but it's not necessarily related to them just by microscopic appearance. Nested, it's just people thought that this resembles like a nest. Sarcomatoid, when a tumor starts forming areas that resemble soft tissue tumors. Giant cells, it's self-revealing what that means. Polymorphic or giant cells, clear cells, when the tumor cells show some clearing within parts of them that give the appearance of clear cell morphology. Small cell, again, the tumor cells are much smaller. And then adenocarcinoma, when the tumor in the bladder looks like a tumor arising in the colon or the stomach or the thyroid when it's forming like an adenocarcinoma or the lung. One thing to keep in mind that although these are unique, different histologic subtypes, except for an adenocarcinoma, they all arise from a urothelial carcinoma background. An example here would be in this tumor that has glandular differentiation, a big part of the tumor is still urothelial, but it's just this unique, the shape of this structure that is part of the tumor that looks like a gland gives this tumor the term of glandular differentiation. The same with the squamous, the same with the small cell and the sarcomatoid. So these names, you may read about them, you may hear them. They are descriptors of how the tumor looks like under the microscope. And this is the gold standard of how these diagnoses are made. Just to summarize all of this and just give you some pointers here, we can use divergent differentiation when a tumor starts at the urothelial and starts showing features that resemble other organs or other structures, squamous, glandular, trophoblastic. Usually there is a urothelial component. There are some nuances. You may hear them as variant histology. It refers to the same. You may hear the names as histologic subtypes or rare subtypes. All of them convey the same. People have used different terminologies to describe them, throughout the decades of recognizing these tumors. So just keep that in mind, variant, subtype, differentiation. This may refer to the same in the bladder setting. As I mentioned, this is all based on examining tissue sections. Are they taken from a biopsy or a resection specimen under the microscope? And by the appearance of these tumors under the microscope, that we use these different terminologies: urothelial, histologic subtypes, variant histology. Overall, they still remain small subset of these, a minority of urothelial carcinomas will be of this subtype. And because of that, most of studies that you read in the literature, they may group them together as all variant histology of urothelial carcinoma or histologic subtypes as in one entity. I'm going to show you in the subsequent slides that this is not necessarily advisable because there's some unique features that are related to each subtype. But again, for practical purposes, just to come up with enough numbers to be able to come up with some conclusions, there is a tendency to group these entities together. And how rare or how prevalent they are, depending on how much you examine and how you look. If you have parts of the tumor in a TUR, transurethral resection specimen, it's about 15%. If you have a cystectomy of the bladder, you have more tissue to examine. The chances that you'll find variant histology or histologic subtypes is higher. We generally associate them with higher stage or advanced disease. They tend to be, unfortunately, under-recognized, maybe because of lack of awareness or lack of experience or expertise with these entities. Not every place has specialized people who look at these entities all the time. So that because of that, some of these subtypes may be under-recognized or under-reported, which may be problematic because, as we will see from my slides and from the slides from Dr. Lee afterwards, that the type of histology subtype that is made, the diagnosis of which is made, may have a serious impact on what type of treatment the patient may get, or not necessarily. Part of the treatment also it may determine if a patient get enrolled in a clinical trial or maybe denied certain treatments just because they have more of a histology subtype, or if that subtype may not have not been even recognized. All of these factors and challenges of the histologic subtypes. The end result of that is they remain understudied, and there is a kind of unmet need in the field of urothelial carcinoma, and there is an opportunity there for us people who are interested in this and for our patients to try to study these tumors and try to understand them as much as as possible, or as we would like to. These are just two examples. I didn't mean to give you a lot of details here. They may not necessarily be practical, but these are two examples why these subtypes or these histological subtypes may not be recognized. Sometimes local pathologists, local hospitals, small practices may not necessarily be aware of them. They may send these cases to an experienced center or specialized centers. Then this is when these histologic subtypes or new diagnoses may start coming up in the report that was not present in the initial report. So if a more specialized center reviewing material from other smaller centers, or sometimes when people they want to do research and retrospective cases, archived material in their institutions. This is an example of Mayo Clinic. You may go back, and while you're examining these cases to study them, you realize that some of these histologic subtypes might have been missed or overlooked. And in this example, about a third of cases that were not called any histologic subtypes were discovered to have one form of histologic subtypes. As I mentioned, these subtypes are relevant, are important, because they don't behave the same. If you have one subtype, a patient may have a different risk versus having another subtype. But this is a large study that came out recently from our group, but there are many similar studies from other groups showing similar results. The writing may be small, but they can see each line represents one histologic subtype, and each line is associated with different risk of recurrence and survival. Worst actors are tumors with the name of plasmacytoid urothelial carcinoma or sarcomatoid urothelial carcinoma. There are some tumors that are in between, like squamous differentiation, micropapillary, small cell carcinomas, and then the NOS is one of the kind of more favorable histologic subtypes. So they're not the same. So it's important not to confuse everything as variant histology. It's important to ask the question, what type of variant histology or what type of histologic subtype that any patient has, because that may determine different risks, risk for recurrence and metastasis, and also may determine different type of treatment that they may get. Unfortunately, because of their understudied overall, we don't know exactly what leads to one histologic subtype or the other. We know some of them. We know, for example, plasmacytoid carcinoma has a unique genetic abnormality. Part of the genes that make up the tumor is mutated or altered. It's called CDH1 or E-cadherin. Most of the other histologic subtypes share similar mutations or genetic abnormalities to urothelial carcinoma, with some differences. For example, micropapillary carcinoma have higher rates of HER2 mutations or amplifications. Small cell carcinomas have higher rates of RP and P53 mutations. Again, these are, apologies if these are too technical, but these are some of the genetic events that people in the field know about them, and we use them to help us determine, the diagnosis sometimes, or inform us of the characteristic of the tumor or the disease that can help us devise management strategies.